There are a variety of liquid biopsy tests currently available for clinical use in cancer. The first are CTC-based sequencing methods for which circulating tumor cells are isolated and those specific tumor cells are sequenced. There are also next-generation sequencing methods for plasma-based DNA that's shed by the cancer. These are the cell-free DNA approaches. Depending on the clinical question being asked, there may be strengths and weaknesses to testing for a specific type of liquid biopsy. Traditionally in my practice at diagnosis, I'm looking for a broad panel to cover all the NCCN recommended genomic aberrations as well as some others that may be amenable to targeted therapy. And so for my own clinical use, I tend to use a cell-free DNA panel, often a next-generation sequencing cell-free DNA panel, to capture the broadest number of genes that may be clinically relevant for my patient. So many of our patients who are diagnosed with a driver mutation for their non-small cell lung cancer, EGFR, ALK, ROS1, but also other types of driver mutations, BRAF, HER2, MET exon 14, can develop resistance to targeted therapies. And often that resistance relates to changes that happen in that specific gene. And so for EGFR, that's often T790M or sometimes C797S. In the doubly resistant setting. For ALK, there are various mutations, including L1196M and various others that may confer sensitivity or resistance to a variety of different target agents that are currently available. And so at progression for a patient's targeted therapy, we know which specific gene we have to look at. And so whether the similar NGS approach or a more specific CTC approach is required depends on the clinical context and the particular patient. But oftentimes we'll use the same assay that we used at diagnosis to make sure we have consistency in results and to check the preferential changes in percentages in cell-free DNA that can occur over time.
The first setting where I send a liquid biopsy is when there is time pressure. A patient presents who I need EGFR genotyping on, and the tissue is at the pathologist. They aren't done yet. They're working on it. But I want an EGFR result today. And so we have launched at our own center a rapid EGFR test where I can send a specimen of blood and get an answer back in a couple of days that tells me in a patient who's shedding, I can find EGFR mutations. And so in some of my patients, that allows me to start targeted therapy quickly without waiting for the tumor result. In a patient with cancer-related symptoms, in a patient with brain mets where I'm trying to avoid brain radiation, this is a rapid approach that gets me an answer quickly and gets me to a treatment option. Here's a second patient. Their cancer is aggressive, they're symptomatic, they need treatment today. What do I do to make genomics a backup plan down the line? I send a liquid biopsy panel that's going to take a few weeks perhaps, and I start chemo. And in a few weeks down the line, I know how they're doing on chemo. If chemo isn't working, I've got that panel test back to tell me what my backup plans are for the second line. Or another patient, they have progressive cancer, tissue's inadequate, I'm sending them for radiation for a couple of weeks. I send a panel-based liquid biopsy, and that will get back in time for me to plan systemic therapy. But I'm always thinking about the turnaround time of my diagnostic test that allows me to get a genotype for an ungenotyped patient when tissue is not an option. The second broad setting where I'm using liquid biopsies is at resistance. We now have a drug, osimertinib, that is only approved for a resistance mutation, T790M. And if I want to use this drug, I need to figure out in a patient with an EGFR mutation and resistance, what is the type of resistance they have. And so I talk about a biopsy, the patient doesn't want a biopsy, I try a liquid biopsy first. If the liquid biopsy finds T790M, that allows me to go down the targeted therapy route. If the liquid biopsy is negative, I go back to the patient and I say, we need that tumor biopsy to get us to an answer and to create targeted therapy options like osimertinib as an alternative to chemo. And so the two main categories for using liquid biopsies are the ungenotyped patient where you need to find their genotype, or the patient with resistance where you need to figure out the characteristics of their resistance.